Medtronic technologies impacted more than 72 million people in the last year, equating to 2 people every second. Harnessing the power of technology to take healthcare further, each technology has unique benefits designed to serve patients. The goal of this program is to get closer to the patient and delve into the challenges and impact of each technology in practice. This is the Medtronic MedEd Learning Experience. The Invos monitoring system should not be used as the sole basis for diagnosis or therapy and is intended only as an adjunct in patient assessment. The contents and conclusions of the following programs are solely those of the speakers unless otherwise cited. The speakers are responsible for all content and any necessary permissions. The speakers receive funding from Covidian LP, a Medtronic company, for this speaking engagement. Medtronic's medical education programs are offered to provide attendees education on FDA-cleared indications and use of our products when applicable. For this segment of the series, a discussion on the utility of Invos system. What does the literature say about NIRS oximetry? To answer this question is Dr. Ronald Bronicki, Professor of Pediatrics at Baylor College of Medicine, Section of Critical Care Medicine and Cardiology at Texas Children's Hospital.
There has not been a prospective randomized trial that has evaluated the impact of NIRS oximetry on outcomes. There has not been a prospective randomized trial on any monitoring modality that has demonstrated a favorable impact on outcomes, including pulse oximetry. There have been numerous prospective observational and retrospective studies on NIRS oximetry, primarily in neonates and infants with congenital heart disease undergoing cardiac surgery, and more recently studies in premature neonates, which have evaluated the potential role of cerebral NIRS in preventing neurologic injury in these high-risk patients. This is one of many studies that have demonstrated a significant association between intra- and postoperative cerebral NIRS and neurologic outcomes. This particular study found a significant relationship between intraoperative cerebral oxygen saturations and neurodevelopmental outcomes. NIRS oximetry has played a pivotal role in delineating the perioperative pathophysiology of single ventricle physiology, which has proven to be particularly useful in the management of neonates prior to and following the NORD procedure. Hoffman and colleagues demonstrated the limitation of relying on blood pressure as an indicator of systemic oxygen delivery. They demonstrated the role of cerebral NIRS in providing a timely and accurate indication of systemic oxygen delivery. They also demonstrated the propensity of pulmonary overcirculation occurring at the expense of systemic perfusion. In this analysis, they demonstrated that renal or somatic NIRS oximetry provided an earlier indication of a falling systemic oxygen delivery than cerebral NIRS alone or central venous oxygen saturations. Specifically, that the difference between cerebral and renal oxygen saturations provided an earlier and much more robust indication of a falling systemic oxygen delivery than cerebral oxygen saturations or central venous oximetry. Perinatal asphyxia in term and preterm neonates causes cerebral injury, including IVH and PVO, which leads to adverse neurodevelopmental outcomes. These investigators demonstrated that preterm neonates with IVH had significantly lower cerebral NIRS during the immediate transition following birth. Not surprisingly, there was no relationship between either the arterial oxygen saturation or heart rate and the development of IVH. In a subsequent study, the feasibility of reducing the burden of cerebral hypoxia during the immediate transition after birth was evaluated. Cerebral hypoxia was defined by the time spent with a cerebral NIRS at less than the 10th percentile. Reference ranges which had been previously established in preterm and term neonates not requiring medical support at birth. The intervention was manipulation of respiratory support, which included airway pressure and supplemental oxygen. This figure demonstrates the difference in cerebral NIRS between those receiving therapy for depressed cerebral NIRS, the NIRS visible group, and those patients where the cerebral NIRS was not visible, all in reference to the 10th percentile for normal cerebral NIRS at specific time periods during the transition period. The 10th percentile is represented by the dotted line. This figure demonstrates, 1, the feasibility of accomplishing a cerebral NIRS value of greater than the 10th percentile throughout the immediate transition period, and 2, the difference between groups was significant during the initial 10 minutes or so of the transition period.
Please tune in next week for a new segment from this series wherever you find your podcast. This is the Medtronic MedEd Learning Experience. Thank you for listening.